So in the first section, let's start with the Toxoplasma gondii. This is the most common causative organism of the toxoplasmosis. We will talk about what is the congenital toxoplasmosis, how it develops, what's the life cycle of Toxoplasma gondii, and then transmission and pathogenesis of toxoplasmosis, pathology and host immune response. So what is toxoplasmosis? Toxoplasmosis is caused by infection with obligate intracellular parasite Toxoplasma gondii. So Toxoplasma gondii cause toxoplasmosis, and this is intracellular parasite. Acute infection acquired after birth. So we have congenital toxoplasmosis, which is the infection that is present at birth, or it is acquired after the birth as a result of vertical transmission from the mother to the baby. So acute infection is acquired after birth. It may be asymptomatic, or it may result in chronic persistence of cysts in host tissues. So it may be asymptomatic, or it may have chronic persistence of cyst in the host, and it is acute infection developed after the birth. Toxoplasmosis is caused by obligate intracellular parasite known as Toxoplasma gondii. In both acute and chronic toxoplasmosis, we know that now that acute is short-term, chronic is long duration, and in both acute and chronic type of toxoplasmosis, the parasite responsible for clinically evident disease including lymphadenopathy. Also encephalitis, myocarditis, pneumonitis. So once toxoplasmosis progress, it can cause to serious complications or serious manifestations like encephalitis, myocarditis, pneumonitis. So it involves the heart, lungs, brain. The lymph nodes become enlarged. So it's a serious condition with manifestations of different systems or multi-system infection. Now the congenital toxoplasmosis. Congenital means present at birth. So congenital toxoplasmosis is an infection of newborns that results from the transplacental passage of parasite from a mother to the fetus. So congenital occurs as a result of vertical transmission of the parasite from the infected mother to the babies, causing congenital toxoplasmosis. Here, if you see, that's the test done with the heel prick of the newborn babies, and the blood is put on the sample, on the test paper, and then it's tested for the toxoplasmosis and for any other abnormalities. Infants may be asymptomatic at birth. So infants, once they have congenital toxoplasmosis, they may have no symptoms present at birth. Signs and symptoms are the chorioretinitis, strabismus, epilepsy, and psychomotor retardation. So congenital toxoplasmosis is a serious condition, cause even mental retardation. In immunocompetent individuals, in patients who have normal or have a competent immune system, the toxoplasmosis can also present as acute disease, typically chorioretinitis associated with food or waterborne source. So in children, usually there is acute disease, and in adults who were immunocompetent, they sometimes present with the acute disease in which we see chorioretinitis typically present. And in associated, what are the source of transmission is through the food and the water. Cause of toxoplasmosis and how it is spreading, we have asexual stages. From the asexual stages of Toxoplasma gondii, cysts with bradyzoites or sporulated oocysts ingested by host. Cyst rapidly digested by acidic pH gastric secretions. Then we have bradyzoites or sporozoites enter the small intestinal epithelium and form tachyzoites. Tachyzoids replicate in all mammalian cells except red blood cells. Parasite actively penetrates cell, forms parasitophorous vacuole. After reaching critical mass, intracellular signaling within host and parasite occurs. Host cell is destroyed and tachyzoid infect adjoining cells. Eliminate by host humoral and cell-mediated immune responses. So that's the whole mechanism or the reproduction by which they grow, and they leave the cause destruction of the host cell and eliminated from the host body by the humoral and cell-mediated immune responses. So asexual stage cause cyst with bradyzoites or sporulated oocysts ingested by host. Then these cysts rapidly digested by the acidic pH of gastric secretion. Bradyzoites, sporozoites enter the small intestine where they form tachyzoites, and then we have it penetrate the cells, form parasitophorous vacuoles, and then it causes. So all that is the kind of life cycle of the causative agent. Tissue cysts develop 7 to 10 days after systemic tachyzoid infection. So, tissue cysts develop 7 to 10 days after the infection. Tissue cysts persist within central nervous system and the muscles. Development of this chronic stage complete the asexual portion of the life cycle. Active infection in immunocompromised host is due to release of encysted parasite. So in immunocompromised, not in immunocompetent, we see the chronic type of infection or chronic toxoplasmosis that is due to the release of the encysted parasites that are present in the body. Now, just simply the life cycle again of Toxoplasma gondii. It can spread through blood transfusion from mother to the baby, and also human contamination occurs from the cat feces, from contaminated food and water, raw or undercooked meat. So all these are the different sources from which the infection can occur. reach to the humans, especially in small children when they play on the ground and they come in contact with the cat feces usually, and then they touch other food particles or food products, then they get ingested. So these are all the means of the transmission. In the herbivores contamination, we have tissue cysts, then cat become contaminated. From the cat, the fecal oocysts are released, and then they can infect the other insects, the birds and the mouse and other herbivores. So this is the means of the transmission or life cycle, spread through the blood transfusion from the mother to the baby, contamination from the cat feces, eating the contaminated food, water, and from eating the raw or undercooked meat. After the asexual stage, which was all about the cyst and the trophozoite formation, now the sexual stage of the Toxoplasma gondii takes place in the cat, which is the definitive host. Definitive host of Toxoplasma gondii is the cat. So people who keep the cats at home, they need to be very, very careful because they need to take care of the litter. Sexual stage is defined by formation of oocyst within the feline host. Begins with ingestion of bradyzoid tissue cyst and ends in the production of gametes. Zygote produced, secreted in the cat feces. Air exposure, the oocyte sporulates to produce sporozoid progeny. Sporulated oocysts can be ingested by the intermediate host, and then in intermediate host, the Toxoplasma gondii complete its life cycle. So we have asexual stage, we have sexual stage. Asexual stage is in the intermediate host like humans and herbivores. The sexual stage is in the cat, and then the oocysts are released in the cat feces, and then they sporulate and taken up by the intermediate host. The epidemiology is infects range of mammals and birds. Seroprevalence depend on the area and the age of patient. Hot and climatic conditions associated with low prevalence. So area which have hot arid climatic conditions, the prevalence is low. In US, seroprevalence increases with the age and exposure. In Central America and in France, seroprevalence is higher. Prevalence decreased due to awareness. So once the people are aware that this thing can occur, they take precautions, and then it causes decrease in the prevalence. So it's less common in the area which have hot, arid climatic conditions, but it's more in the France and Central America. Transmission, oral transmission is due to ingestion of sporulated oocyst, oral transmission through consuming the contaminated food, water, undercooked meat, that all is in the oral transmission. Can be due to undercooked food or inadequate freezing of the food. Direct ingestion causes acute infection. If the transmission is through the blood or organs via blood transfusion, via seropositive donor to negative recipient, reactivation occur in the B, M, and HSCS. PCR polymerase chain reaction screening of blood is done in the patient. Transplacental transmission, one factor that is important is gestational age, which is at the time of infection. Seropositive women protected before pregnancy. 20% of infected women develop clinical signs. Pathogenesis upon host ingestion of cyst or sporozoites, parasites released by digestive process. Bradyzoites resistance to effect of the pepsin. Within enterocyte morphologic transformation, so bradyzoites can change to trophozoites in the enterocyte cells of the intestine. Induction of parasite-specific secretory IgA response. Disseminate to variety of organs like lymphatic tissues, skeletal muscles. Parasite infects the host cells and replicates. Cell death and necrosis occur with acute inflammatory response. So as with other infectious diseases, we keep on mentioning that once the infection occurs, it stimulates the inflammatory process, and as a result of that inflammatory process, different cytokines and inflammatory products are released that causes the death and necrosis. So that's the same mechanism is occurring in the toxoplasmosis. In immunocompetent host, humoral and cellular immune response control the infection. Parasite virulence and tissue tropism is strain specific. Tachyzoites sequestered by immune mechanism, induction of parasitidal antibody, activation of macrophages with radical intermediates, production of IFN gamma, stimulation of CD8 and CTL. All these are different inflammatory now products. After clearance, cysts containing bradyzoites appear. Toxoplasma secretes signaling molecules modulating host responses. Ability to eliminate cysts depend on the genetic background of the host. Now, the immunocompromised or fetal host, immune factors are lacking because in immunocompetent we mentioned that humoral and cellular immune response is activated and cause and fight against the infection. But if the patient is immunocompromised and if they are fetus or newborn, then we have it's hard to fight because their immune system is compromised. Persistence of tachyzoites cause progressive focal obstruction and organ failure. Infected individuals, persistent infection with cyst having bradyzoites. Bradyzoites in slow metabolic phase, cysts do degenerate within central nervous system. Degenerative process, source of recrudescent infection. In rodents, infection affects behavior, increasing the predation of the rodents. Cell death and focal necrosis occur due to replicating tachyzoites. Mononuclear inflammatory response in tissue. Tachyzoites rarely visualized by histopathologic staining. Immunofluorescence staining with parasitic antigen-specific antibodies are used for visualization. Cyst reached maturity, inflammatory process no longer be detected, remain quiescent. Lymph nodes, what are the pathological changes in the lymph nodes occur? We have follicular hyperplasia, granulomas rarely evident. Irregular clusters of macrophages with eosinophilic cytoplasm. PCR amplification. In the eyes, there is infiltrates of monocytes, lymphocyte PCs. Granulomatous lesions and chorioretinitis, cataract, glaucoma, or iridocyclitis. In the central nervous system, focal and diffuse meningoencephalitis, necrotizing encephalitis is present. Then we have polymorphonuclear cells, PCs, monocytes infiltration in the central nervous system also. In the lungs and heart, interstitial pneumonitis development, edematous alveolar septa, bronchopneumonia, focal and hyaline necrosis, pericarditis. In gastrointestinal tract, there are ulcerations present, IBD, inflammatory bowel disease, infection by human intestinal epithelial cells. In the other sides, we have skeletal muscles, pancreas, stomach, kidney necrosis. Then we have direct tissue destruction and secondary effects. Now, host immune response that develops, there is toxoplasma enters the host at the gut mucosal level. Evokes production of antigen-specific IgA. This IgA titers of serum IgA antibody detected at P30SAG1, which is a useful marker. Milkway IgA from acutely infected mothers block infection of enterocytes in vitro. So that's how the host immune response developed, mainly by the production of antigen-specific secretory IgA, and these titer of serum IgA antibodies against a useful marker is detected. Detectable levels of both IgM and IgG antibodies are present, and we have monoclonal gammopathy of IgG class. IgM levels may be increased in newborns. Polyclonal IgG evoked by infection, which is parasitidal in vitro. Cell-mediated immunity, major protective response, macrophage activated after phagocytosis. So all these factors are increasing the host immune response, production of IgA, then we have IgM, IgG, activation of the macrophages, and these are different host immune responses. Death of parasite by oxygen-dependent or independent process. Toxoplasma cause interleukin-12 response by the dendritic cell DC. Co-stimulation via CD40/154 is established. CD4 and CD8 plus T cell responses, they are antigen specific. Stimulate production of lymphokines. Toxoplasma gondii of Th1 phenotype with IL-12 and IFN gamma playing role, regulation of inflammatory response, control of Th2 response, production of interleukin 4, 10 in seropositive individual. So all these factors are responsible for host immune response in the toxoplasmosis. Asymptomatic patient, they have CD4 to CD8 ratio correlated with disease syndrome. Human T cell clones of CD4 and CD8 phenotypes, they are cytolytic. T cell clones produce cytokines that are microbiostatic. Interleukin 18, 7, and 15, they upregulate the production of IFN gamma. Antibody titers not useful in establishing the reactivation. Absence of positive serologies leads to alternative diagnosis. T cells from AIDS patient not secrete IFN gamma and interleukin 2, persistence of infection, and infection develops late in the course of AIDS patients. That was all about section 1. Thank you for watching sqadia.com.